So thank you, Professor G, and it's a very pleasure to hear the talk from Lisa. So I'm quite interested in the therapeutic strategy for EGFR mutant stage 3 non-small cell lung cancer, and we know that the stage 3 non-small cell lung cancer is not surgically resectable. But if we could use some strategy to make this unresectable cancer become resectable, then we will cure the disease. So so the aim of the treatment may be disease downstaging, and we may use so for patients with EGFR mutant stage 3 non-small cell lung cancer, treatment with targeted therapy may be an option. But our experience in previous clinical trials suggests that neoadjuvant therapy with the first generation EGFR TKIs failed, because I think the key question is the duration of neoadjuvant therapy with tyrosine kinase inhibitors should be mentioned. In the past clinical trials, the patients usually treated with tyrosine kinase inhibitor for about 8 weeks. I think this is not enough to make the disease downstaging, and if we extend the duration of the treatment, and maybe we could increase the possibility of major pathological response or complete pathological response. This is one question. Another question is, so in the past trials, we use first generation EGFR TKIs. I think these drugs is not potent enough to efficiently suppress the EGFR signaling. So if we could use the third generation EGFR TKIs, such as osimertinib and amanitinib, just showed in Lisa's slides, then so we can use the third generation EGFR TKI to make disease downstaging and make the unresectable non-small cell lung cancer become surgical resectable. The last aspect of my view is that the role of immunotherapy for EGFR mutant lung cancer. So we know that patients with EGFR mutation did not benefit from the Pacific trial. That's because the EGFR mutant non-small cell lung cancer is not immunogenic, and these tumors cannot trigger efficient anti-tumor immunity to kill the cancer cells. So I think combination will be could be an option for this patient if we consider to use immunotherapy. So that's all.
I think these are very interesting questions, and I think so most clinical trials with neoadjuvant EGFR TKI, indeed, if you look at the emerging trial, erlotinib or chemo, you had a DFS benefit but no OS benefit, and almost no pathological complete response or major pathological response. We have the for the NORA, the NEOS, and an American trial also with neoadjuvant osimertinib. Then I think in the end, the majority of this was really unresectable, so not unresectable. So the majority of patients proceeded to surgery, but again, almost no pathological complete response, no major pathological response. And I think these trials used 8 weeks. So if you look at the aumolertinib 16 weeks for unresectable, maybe is indeed the strategy. If you want to make something resectable, give the EGFR TKI longer. But I think that's mainly to improve resectability. I think if you want to improve the pathological complete response or major pathological response, then I think based on the trials, the OC trials, but also the aumolertinib trial, I think it's not enough. Although in the aumolertinib trial you had a little bit more major pathological and pathological complete response, it's still a low percentage. You can add chemotherapy. We will have next week ASCO the neo-ADAURA data. I think it's still under embargo, so yeah, we should discuss this after ASCO. But not sure, I think, whether this will be the way forward or that we should have other strategies to really induce pathological complete response and major pathological response. I know in the metastatic setting, combination strategies with chemo, angiogenesis inhibitor, and immunotherapy, it is suggested that maybe this can make the tumor more immunogenic, but that's, I think, more difficult if you want to resect, because angiogenesis inhibition can increase the complication rate. There are also trials ongoing, but with really early phase clinical trials with vaccines, for example, or even CAR T cells for EGFR. I think that it's way too early to test these things in the non-metastatic stage, but I think we should look at the metastatic stage to learn how we can improve for the non-metastatic stage. But I think for me, maybe now the neoadjuvant EGFR TKI is mainly to make something not resectable.
So we have a number of patients to receive the third generation EGFR TKI and achieved a complete pathological response, but we extend the duration of treatment up to 10 months. Yeah. So if we extend the duration of treatment, that will cause more difficulties for surgeons, because severe tissue adhesion could be observed during the surgery. Yeah. And I think the magnitude of response to targeted therapy maybe predict therapeutic outcomes. So if the tumor shrinkage is more remarkable to the treatment, and I think this patient will gain higher possibility to achieve MPR or PCR.
Yeah, I fully agree with you, and I think also in China, yeah, it's I think ideal to do these type of clinical trials. In Europe, it's really a limited number of patients with an EGFR mutation. It's usually 10%, maybe 15%, and in some regions it's even lower. I think with the number of EGFR positive patients you have in China, I think it's really good if you have these clinical trials also with biomarker parts to really tease out which patients benefit from this type of treatments. And I think in China you can do this.
Okay, thank you so much.